Endocrine emergencies are commonly encountered in pediatric emergency practice, and it's one condition which, if we are able to pick up, would be able to treat it immediately with a very successful outcome. There also are impact of illnesses on the endocrine conditions which can cause confusion with regards to assessment and diagnosis, and careful consideration, evaluation and management for an endocrine cause in any child presenting to us in the emergency room becomes absolutely essential in this regards to achieve a good outcome. To highlight this, we'll start off with this case whom we saw a few years ago in our ICU, a 14-year-old boy who presented with drowsiness. The child was euvolemic, he had hyponatremia, and his urinary sodium was found to be on the higher side. So in the setting of a euvolemic hyponatremia with high urinary sodium and high urinary osmolality, a diagnosis of syndrome of inappropriate ADH secretion was established by the treating physicians, and they advised wound restriction. Now, if we really understand the situation, this is a very common condition encountered in the intensive care. Somebody coming to us with hyponatremia who has got a dilute blood, but the urine seems to be concentrated. So SIADH is a likely possibility. However, with fluid restriction, there was a worsening in clinical condition. And when we will discuss about hyponatremia, we'll discuss how it is absolutely important to evaluate for the thyroid and the cortisol axis before labeling somebody as SIADH. So this was actually a case of multiple pituitary hormone deficiency which was masquerading as SIADH, and if we had not initiated the thyroid and the hydrocot replacement at that point of time, he would have had a very severe outcome. So consideration for an endocrine cause is absolutely important as highlighted in this case. This is another case which was really troublesome. This was a 2-month-old boy who was actually admitted around 10 to 15 years ago at AIIMS cardiology department with hepatomegaly and cardiac failure. He had a poor ejection fraction and a diagnosis of dilated cardiomyopathy was considered. He was intubated, and then somebody really did a ECG from a cardiac perspective and found that there was a QT prolongation. It was at that point of time the pediatric endocrine team was encountered, and we found that he had severe hypocalcemia due to vitamin D deficiency. So on both these cases, what we are seeing is that conditions which will present to the emergency room with alternative symptoms like encephalopathy, like altered sensorium, like cardiac failure, they turn out to be an endocrine cause. And very importantly, as against many other intensive care conditions where specific treatments are not available or not very effective, the diagnosis of an endocrine cause is associated with a successful outcome in a vast majority of cases. Therefore, endocrine emergency should be suspected in a wide array of circumstances. Any child presenting to us with encephalopathy and seizures could have hypocalcemia, hypoglycemia or hyponatremia. Somebody with a shock or dehydration may be suffering from adrenal insufficiency, acute diabetes insipidus. Somebody with cardiac failure can have hypocalcemia, hypothyroidism and hypoglycemia. And somebody with acute abdomen can present with adrenal failure and hypercalcemia. And in this talk, we'll be focusing mainly in terms of non-diabetic ketoacidosis emergencies, and of course diabetic ketoacidosis can present with encephalopathy, with shock, with polyuria, with respiratory problems in acute abdomen, because there is an entire complete talk on DKA based upon our MedEClasses protocol which is available on the YouTube in that perspective. So in a nutshell, endocrine consideration should be given for every sick child, and what's very important to do in that setting is to look at electrolytes, look at sugars, and in most cases if we add calcium to that, so sodium, potassium, sugar and calcium will give us the diagnosis in vast majority of cases. What we also need to understand is that illness will have an impact on the endocrine axis. So illness will be associated with reduction in growth hormone levels, which is a physiological response to conserve energy. Similarly, the body will try to conserve this catabolic state of thyroid excess by causing a central hypothyroid-like picture, and this can cause a confusion in terms of assessment. So we'll expect the TSH level to be lower in an individual who presents to us with acute illness. There could be a situation in which the ACTH and the cortisol axis can actually be altered, resulting in a pseudo-Cushing state. So when we are interpreting a child in an emergency state, we have to be very careful in terms of interpretation of endocrine function. Importantly, do not do a thyroid function in any sick child unless there are classical features of hypothyroidism. Suppose you have a child who presents to you with severe bradycardia, severe hypothyroid symptoms, encephalopathy, then do a thyroid profile. Otherwise, it will cause more confusion in that setting. Similarly, every sick child in the ICU should have a cortisol level which is more than 550 nanomoles per liter. If the cortisol level is lower, you should think of a possibility of a cortisol deficiency in that perspective. So endocrine emergencies are common in pediatric practice but are often missed. They respond dramatically to therapy, and lack of diagnosis results in adverse consequences, highlighting the need for high index of suspicion, careful assessment, and appropriate treatment. To ensure that we have a uniform management across board, we have launched our intensive care endocrinology course as part of our MedEClasses courses. It includes around 12 modules covering each and every aspect of hypocalcemia, hypercalcemia, hypernatremia, hypokalemia, diabetic ketoacidosis, DSD. So all that we are discussing here are there in much more detail. We of course have our Master Pediatric Endocrine online course, which constitutes around 85 modules with over 200 hours of video lectures covering every aspect of pediatric endocrinology. And to ensure that we go from clinic to the book and back, we've got a MedEClasses app which really provides extensive ways to approach and manage endocrine conditions, particularly in the intensive care setting. This MedEClasses app, which is available on both Android as well as iOS store, has got extensive approach pathway, personalized management pathways which allow appropriate management of a variety of pediatric endocrine perspective, which provides uniform access, and we'll be using some of these technological interventions to improve care, and we'll show how it can improve the management of cases. The app basically concludes a number of pathways. So if you want to go on an approach pathway, it will ask questions, and based upon those questions, it will then finally reach a particular diagnosis. We can have a specific management pathway based upon the personalized inputs which are given. Specific therapy and modifications are available from there. So what are we going to do over this talk is basically to cover the 6 key aspects of pediatric endocrine emergencies, namely hypoglycemia, hypo and hypercalcemia, hypernatremia, hypokalemia, disorders of sexual development, impact on thyroid, of emergencies and thyroid as emergencies, and of course adrenal disorders. As discussed, diabetic ketoacidosis is available as a MedEClasses module on our masterclass playlist of the YouTube channel, and we can access it from there. Now we'll go one by one. So we'll start off with the first case, 1-week-old boy with seizures, sugars of 28 milligrams per DL, and this is a common consideration: what to do, whether to evaluate, when to evaluate, how to evaluate. And to understand that, we need to have a basic understanding of glucose physiology. We know that the fetus is entirely dependent upon glucose as a source of its energy needs, which is around 80%, and very importantly, it does not produce any glucose. There is, however, a passive gradient which is there from the mother to the fetus. So this glucose basically passes through the GLUT pathway passively to the child. So there is around 80% of glucose in the fetus as compared to the mother. So if mother is at 100, the fetus will be at around 80. What it really means is that maternal hypoglycemia would be very disastrous for the baby, because they will then develop hypoglycemia in that perspective. Very importantly, maternal insulin cannot cross the placenta, and this is very helpful. Otherwise, if we give insulin to the mother, it will cross to the placenta and cause severe hypoglycemia. So in a way, while glucose is being supplied from the mother to the fetus is independently developing its own glucose insulin axis. Now, to ensure that the fetus gets enough glucose, and that glucose is basically to build its store and build its body, the fetus does a very, very interesting thing. It basically produces a substance known as the human placental lactogen, which basically induces insulin resistance. And if the insulin is not working well, mother's glucose will go up. So if it goes from 100 to 120, you will have a higher glucose supply to the child. While this is beneficial to the baby, it is responsible for the development of gestational diabetes and worsening of diabetes control in mothers who have a pre-existing diabetes in that perspective. So in a way, fetus is actually inflicting a damage to the mother to extract more glucose in that perspective. Now, what we need to really remember in that perspective is that this excessive amount of glucose in the fetus will then stimulate its insulin secretion, and it will suppress the glucagon secretion. So this high insulin to glucagon ratio is what stimulates fetal growth. So this glucose is absolutely important. If mother is hypoglycemic, the fetus is not going to grow. Along with growth, there will also be a deposition of glycogen in the liver, which will be very helpful when the fetus needs it postnatally, and most of it happens in the third trimester. So those who are preterm will not have enough glucose or glycogen backup in the liver, and therefore will have a risk of hypoglycemia, explaining a higher risk of hypoglycemia in preterm and small for gestational age babies. Now, as soon as the child is born, this continuous supply of glucose, this free supply which has been going off, is cut off. Glucose level goes down. There is stimulation of epinephrine, which causes the blood sugar level to go up, along with a reduction in insulin. Third to this will be an increase in glucagon, and the major mechanism by which this glucose comes in the first 24 to 48 hours is via glycogenolysis or gluconeogenesis. Very importantly, ketogenesis is not very important in the first 24 hours of life. And what does it mean is that ketotic hypoglycemia will not happen in the first 24 hours. So while we talk about evaluation of neonatal hypoglycemia, we say that blood ketones are absolutely important. Please do not measure them within the first 24 hours. And anyway, when we talk about evaluation, we want it to wait for at least a period of around 48 hours, because that is the time when the babies may have a risk of hypoglycemia. So as discussed, a number of changes happen with regards to these time. Then there are so many things happening. The glucose will invariably go down. The lowest level of glucose happens by around 2 hours, and it takes up to 48 hours to the entire glucose machinery to become functional. So in a way, if a newborn is becoming hypoglycemic in the first 48 hours, it is generally not attributable to pathology. However, after 48 hours, every newborn should be able to sustain the glucose level, and hypoglycemia beyond 48 hours is a major cause of concern. So as again some earlier recommendations which talked about evaluation only after 7 days of persistent hypoglycemia, any newborn who is having persistent hypoglycemia beyond 48 hours should be considered with suspicion in this regards, and that becomes extremely important point to consider. Secondly, after 48 hours, the baby should be able to fast for around 5 to 6 hours without having hypoglycemia. So the criteria for discharge of a newborn from an NICU is typically skipping one feed and seeing how the glucose level changes in that perspective. So if a newborn is not able to skip a feed without having hypoglycemia, the child should not be discharged at that perspective. Now, a big question which often comes to us is what really is hypoglycemia? What cutoffs should be used? Now, what's very important to understand that when we talk about hypoglycemia from an endocrine perspective, we talk about the classic Whipple's triad, which says that we should have a low glucose level, symptoms because of hypoglycemia, and these symptoms should improve once we correct that hypoglycemia. Now, this is impossible to achieve in children because we don't know what symptoms are because of hypoglycemia and whether the child is responding or not. So what we talk in terms of hypoglycemia is operational thresholds. So if anybody has a low glucose and symptoms, that's very clear. But if there is an asymptomatic child whose glucose levels are less than 25 milligram per dl in the first 4 hours, less than 35 between 4 to 24 hours, less than 50 between 24 to 48 hours, and less than 60 beyond that age group, we need to do something to correct it. What it means is that if somebody is symptomatic with hypoglycemia, don't bother about these cutoffs, but if somebody is asymptomatic, there is a definite need for correction in that situation. So these cutoffs of 25 below 4, 35 between 4 to 24, 50 between 24 to 48, and 60 beyond 48 should be remembered. Now what we need to understand is that we want to maintain, now these are the cutoffs to act, but once somebody has developed hypoglycemia, we want to maintain the levels higher. So they should be above 50 in the first 24 hours, above 60 milligrams per DL between 24 to 48 hours in that perspective. And if somebody is actually at risk of developing hypoglycemia, we are talking about even higher levels beyond 70 in that perspective. So when do we suspect neonatal hypoglycemia? Definitely anybody with seizures, cardiac failure, apnea, any sick child should be evaluated for hypoglycemia. Screening is indicated for infant or diabetic mother, pre or post term, large or small for gestational age, asphyxia, sepsis, cardiac defects or micropenis, and this should be done at a periodic interval over the first 48 hours because that is the crucial time when hypoglycemia develops. So we need to be very cautious and to pick up at the right time. Now, if we really understand the various mechanisms which really control the blood sugar, we know that the hypoglycemia can happen if the utilization is more because of an infection or a cardiac failure, if insulin levels are high, and this hyperinsulinism is associated with a non-ketotic hypoglycemia, and this is a big message. Every newborn who is hypoglycemic should produce ketones unless there is an insulin excess or there is a fatty acid oxidation defect and rarely galactosemia and fructose intolerance. We can also have hypoglycemia because of deficiency of multiple predatory hormone deficiency in the setting of growth hormone and cortisol deficiency. Remember, while there is only one hormone which decreases glucose, there are four which increases it. So while insulin excess can cause hypoglycemia, in the setting of counter-regulatory deficiency, there are multiple hormones which are superfluous. So unless we have a multiple predatory hormone deficiency, this hypoglycemia does not happen. We need to have a growth hormone and a cortisol deficiency which should be there. Typical features of growth hormone and cortisol deficiency include micropenis, undescended testis, midline defect, cleft lip, cleft palate, and these should be sought off in the situation of a newborn with hypoglycemia. Hyperinsulinism in a classical sense is most commonly observed in the setting of an infant of diabetic mother, but it can occur because of inherited disorders and more commonly now because of prolonged hyperinsulinism, which occurs in the setting of a small for gestational age baby, and hypoxia, which lasts for around 2 to 3 weeks in that situation. While inherited disorders of hyperinsulinism are associated with macrosomia, small for gestational age, and these stressed infants will have a smaller birth weight in that perspective. Glycogen storage diseases and gluconeogenic defects typically present after 6 and 12 months respectively, because if you are getting feeds every 4 hourly, you will not develop hypoglycemic. Fatty acid oxidation defects also tend to present a bit late because there will be a backup of glucose, glycogenolysis, gluconeogenesis, and then fatty acid abnormalities, typically present after around 1 to 2 years of life in the setting of an intercurrent illness like fever, diarrhea, dehydration, and they will become really sick because they will not only have hypoglycemia, they will have toxic metabolites which will accumulate causing problems. So if we talk about major causes of hypoglycemia in childhood, we have hyperinsulinism, which typically presents with macrosomia in the newborn or in the setting of infant or diabetic mother. Fatty acid oxidation defects which present with episodic presentation of high SGPT along with hypoglycemia. Glycogen storage diseases which basically present with massive hepatomegaly. Endocrine deficiency, particularly in the setting of a multiple predatory hormone deficiency presenting with midline defects, growth failure, micropenis, cleft lip, cleft palate. Ketotic hypoglycemia, a diagnosis of exclusion, which should be considered once everything else has been excluded, typically presenting at around 1 to 2 years of age in a lean child who wakes up in the morning for the first time and then is not able to wake up because he develops hypoglycemia. Organic acidemia, typically in the newborn period with severe metabolic acidosis. Glycogen storage disease type 1, 6 months of age, massive hepatomegaly, renomegaly, high uric acid, high triglycerides, ketosis, lactic acidosis. Gluconeogenic defects similar to GSD1 a bit later, around 12 months of life. The most important investigation in a child presenting to us with the complaints of hypoglycemia is ketones. If the ketones are low, we are dealing with hyperinsulinism, fatty acid oxidation defects, and rarely galactosemia, while if ketones are more than 2, a large number of conditions can be there. The second discriminatory investigation in somebody who already has ketosis is lactic acidosis. So if there is ketosis and lactic acidosis, the only two possibilities are GSD1 or a gluconeogenic defect. They will also have acidosis in that perspective. And of course, insulin becomes important. Everybody who is hypoglycemic should have no insulin. Any detectable insulin in the setting of hypoglycemia is hyperinsulinism, and this is something which is very, very important. Glucagon test is very helpful in confirming hyperinsulinism. Anybody who has a non-hyperinsulinemic cause of hypoglycemia should not have an increase in glucose level after glucagon in the setting of hypoglycemia because they have already exhausted the glucagon response. But if there is hyperinsulinism, glucagon will show a response. So just to approach somebody presenting to us with hypoglycemia, the most important thing is to look at ketones. If ketones are low or absent, look at urine reducing substance. If they are positive, we are dealing with galactosemia and fructose intolerance. If they are not, think of hyperinsulinism. If the insulin is detectable in a non-ketotic child with non-glucose reducing substance being negative, it is most likely hyperinsulinism. If it's undetectable, we are dealing with mostly a fatty acid oxidation defect. Other clues to fatty acid oxidation defect are encephalopathy, high SGPT. They will behave like race syndrome in that perspective. If somebody is ketotic and we talk about levels more than 2, and in that regards, again, very important to do a blood ketone assessment, which are easily available now because urine ketones are not very, very reliable in that perspective. So if the ketone levels are more than 2, look at lactate. If lactate is high, we are dealing with glycogen storage disease or gluconeogenic defect. While if ketones are there, but lactate are not there, look for organomegaly. If it is present, it will be GSD3 and 6. If it's not, you have to look for growth hormone and cortisol levels. And if they are normal, you're dealing with accelerated starvation. So the overall assessment of a child with hypoglycemia clearly includes ketones, reducing substances, lactate, blood gas, insulin, and possibly fatty acids, organic acids, growth hormone, and cortisol. And there comes the role of critical sample. So because all these have to be interpreted in the light of hypoglycemia, if you have any newborn who has a glucose infusion rate more than 12 milligram per kg per minute, or anybody who has persistent hypoglycemia beyond 48 hours, and any child with a first episode of hypoglycemia, take a critical sample, the most important of which is to do a ketone. Keep samples for a lactate, for insulin, growth hormone, and cortisol in the reserve. They can be processed as per this protocol as we see here later on if required. Now we have a 3-week-old boy with seizures and hypoglycemia. So the first thing is to look at ketones which are positive. So now we are dealing with the right hand side. Look at lactate. Lactate level is not very high. There is also hyponatremia. So what will cause hyponatremia in the setting of hypoglycemia in a newborn? So we are heading towards something important. Look at organomegaly. There was no organomegaly, but examination gave us a clue. The child had a micropenis. So this is a clear-cut case of hyponatremia, hypoglycemia, and very importantly micropenis. The only likelihood is a multiple pituitary hormone deficiency, which was confirmed by inappropriately low level of cortisol and growth hormone in this setting. Now often you will find cortisol levels in the normal range, but what we need to understand that anybody who is hypoglycemic should have a cortisol level which is more than 550 nanomoles per liter. So if during hypoglycemia your cortisol is 125, which may be labeled as normal for adult range, because that's what the results we'll get, this still means that there is a multiple pituitary hormone deficiency. So any child who has hypoglycemia with micropenis, hypoglycemia with midline defects, hypoglycemia with hyponatremia, always think of a multiple pituitary hormone deficiency. And if we see how our app works, it will basically ask about whether the targets are met, if it's more than 48 hours, So this child is already more than 48 hours. In that setting, we want to see whether he is still having hypoglycemia. Look for ketone levels. Ketone is more than 2. In this situation, it will ask for whether the cortisol is above 550, and we say no. So this is very, very clear that this child actually has a multiple pituitary hormone deficiency, and this application will really take us through very easily, even if we forget all that immediately in the clinical setting. Now, 6-month-old boy with lethargy and blood sugar of 36, ketone positive, lactate high. Now, these are two very, very important clues. And if we put these data into our app, ketone positive, ketone levels are more than 2, lactate above 2. So what we get is clearly GSD1 or gluconeogenic defect. What about this child, 3-week-old boy with failure to thrive? Blood sugar is 30, glucose infusion rate is 6. There is a massive hepatomegaly. Ketone is not there. So what we are looking at in that setting is to look at reducing substances, because ketone is absent. Reducing substances are positive. So this is a case of galactosemia. So all you need to do is to say that there is hypoglycemia which is persistent. The ketone levels are less than 2 and urine is positive. So this is galactosemia. So this is very, very easy to understand in terms of how to evaluate in that perspective. Now coming on to management, we won't focusing much because it's more of a neonatal issue, but definitely we all talk about that if there is symptomatic, you correct it with dextrose, start with glucose. Key message is do not taper glucose quickly. Give the child time to stabilize. It takes at least 48 hours for all the mechanisms to become normal. So if you stop the infusion quickly, you will have a rebound hypoglycemia which will happen. So you should taper it after 48 hours and then you gradually build up as required. Very importantly, the targets less than 48 hours are more than 50, more than 48 hours is more than 60, and anybody who is at risk, we are talking about levels more than 70 in that perspective. Glucose infusion or a bolus is not required in anybody who does not have a symptomatic hypoglycemia in that regards. And because this can be confusing, we have developed an algorithm which takes us through about the symptoms being there or not, then whether the target is achieved or not, what is the blood infusion, how do we taper, and go from there. So hypoglycemia is a common presentation in the newborn period, rare in the postnatal neonatal period, but very significant, needs careful evaluation, management, and assessment in that regards. Once we are through with glucose, we will now move towards calcium, and we have a 7-week-old girl with seizures, calcium levels of 6.6, and again this brings us back to calcium physiology. Now what we need to understand is that like glucose, calcium is also supplied by the mother, and there is an active mechanism for calcium transport using the transporters and calcium ATPase, which allows a significant gradient of calcium from mother to fetus. Thus, while fetal glucose levels are 20% lower as compared to maternal, the fetal calcium level are around 40% higher in that perspective. So fetus is effectively a parasite leaching out all the calcium from the bone and the gut of the mother. 80% of calcium comes in the 3rd trimester. So of course, if somebody is preterm, there will be a risk of hypocalcemia and poor bone development. And the most important regulator of all this is not vitamin D, it is PTH related peptide. So while we talk a lot about vitamin D being an important cause of neonatal hypocalcemia, it's important to understand that it is not important in the first 3 weeks of life. So if you have hypocalcemia in the first week of life, it's usually because of prematurity, infant of diabetic mother, birth asphyxia, SGA. Around 7 days to 21 days, it's hypoparathyroidism, hypomagnesemia, and only beyond 21 days are we talking about vitamin D, because vitamin D does not play a role in both perinatal as well as fetal calcium transfer in that perspective. So there is a 1.4:1 gradient which is established between the mother and fetus. So fetus is having higher calcium, and this is achieved by leaching out calcium from the bones of the mother using PTH related peptide and getting the calcium from the intestine by increasing the calcitriol level. Now, despite this calcium factor, PTH is independent. So, fetal PTH will basically be independent of this placental changes and will respond appropriately in that regards. Now, as soon as the child is born, this calcium will go down, and this will result in increase in PTH and decrease in calcitonin. And these are the two major mechanisms which ensure that the calcium levels is normalized. Individuals with infant of diabetic mother have an abnormality of calcitonin, which causes hypocalcemia. Now, vitamin D plays a role, but it is minor in the first 3 weeks of life, and as discussed, a typical vitamin D deficient child will not have hypocalcemia in the first 3 weeks, and this gives us a window of opportunity of giving vitamin D to avoid this lethal complications. Now, as with glucose, the calcium levels also dips, and the lowest levels are achieved by around 24 hours, then they stabilize by around 1 month to remain stable. The fall is much more for the preterm newborns who have a higher risk of developing hypocalcemia. So, hypocalcemia is one condition which should be suspected in a wide variety of emergency settings, including unexplained seizures. Any child with seizures, even chronic epilepsy, get a calcium. I have seen patients with hypoparathyroidism which are missed, and this is something which should not be missed in this situation. As discussed, any newborn with cardiac failure, anybody who has got a calcification of CT scan, this could be hypoparathyroidism or pseudo-hypoparathyroidism. Anybody presenting with raised ICT, benign intracranial hypertension, papilledema, anybody with laryngotracheobronchitis picture, stridor, and of course long-standing cataract, think of hypocalcemia. Screening for hypercalcemia should be done in those who are premature, small for gestational age, and those who have a conotruncal defect because of a possibility of DiGeorge syndrome in that perspective. Now, hypocalcemia can be because of increased chelation of calcium, because of high levels of phosphorus or other compounds, abnormalities in PTH formation or action, abnormalities in vitamin D, those of calcium sensing receptor in that perspective. Now, very important to remember is that everybody who is hypocalcemic should have hyperparathyroidism, and because PTH causes decrease in phosphorus level, secondarily hypophosphatemia. So, every child with hypocalcemia will have low phosphorus levels unless there is a parathyroid deficiency, parathyroid resistance, or renal failure. This makes phosphorus the most important investigation, as ketone was for hypoglycemia, to classify a child with hypocalcemia. Now, phosphorus load is an important cause in the setting of tumor lysis, rhabdomyolysis, hemolysis. Alkalosis is very important. If an individual has a respiratory or a metabolic alkalosis, this will increase the negative anion level, causing more binding of calcium, causing an ionic hypocalcemia. And this is commonly seen in the setting of renal failure. When somebody has a metabolic acidosis and a low calcium, this acidosis compensates, it can show that there is more ionic calcium. You give him soda bicarbonate, suddenly the binding of this calcium to the ionic part becomes more, ionic hypocalcemia and tetany. So whenever you are giving soda bicarbonate to somebody with renal failure, please always think of calcium. Do a calcium, give calcium, or do a ECG monitoring. Respiratory alkalosis is an important cause of tetany, and this may happen in the setting of a functional disorder causing hyperventilation. It may also cause a problem in newborns who are hyperventilated causing respiratory alkalosis, and this is something we should be careful about. Exchange transfusion, of course, will result in hypocalcemia, and we have to be careful. Parathyroid related problems could be deficiency in parathyroid or resistance in parathyroid, and always remember that magnesium is essential for PTH release and action. Hypomagnesemia should be considered in every person who has a persistent hypocalcemia. Do not do any other workup unless you have excluded magnesium deficiency in that perspective. Vitamin D related causes can include vitamin D deficiency, anti-epileptic drugs which cause inactivation of vitamin D, typically phenytoin, carbamazepine, chronic kidney disease, vitamin D dependent rickets type 1 or vitamin D dependent rickets type 2 in that situation. And finally, we can have a rare situation of a calcium sensing receptor defect where body senses there is too much calcium, so the PTH goes down, there is hypocalcemia. The kidneys is pushing out calcium, causing hypercalciuria. So approach to a child with hypocalcemia should start off with assessment of the magnesium, albumin and the phosphorus load like rhabdomyolysis, tumor lysis, hemolysis. If all that is excluded, look at phosphorus. If phosphorus is low and normal, please recheck magnesium. If this is normal, this is mostly vitamin D related. Look at vitamin D levels. If it's normal, this could be rarely a vitamin D dependent rickets, which requires calcitriol. Do not do calcitriol level in everybody with hypocalcemia. It's a waste of money. The only role of calcitriol in hypocalcemia is to differentiate vitamin D dependent rickets type 1 from vitamin D dependent rickets type 2. So while we say that endocrine workup is very expensive, we realize that if we do basic workup, we can save a lot of money for the patient. In hypoglycemia, we said look at ketone, which is very, very simple, and this will give you the most diagnosis. Look at urine reducing substance, look at lactate, and 90% diagnosis is done. For hypocalcemia, look at phosphorus, magnesium. Then required, you can think of vitamin D. Do not do calcitriol unnecessarily. If the phosphorus is high, do a creatinine. High, it is chronic kidney disease, normal PTH. If the PTH is low, it is hypoparathyroidism, and if it's high, it is pseudo-hypoparathyroidism. One big word about PTH, it is a highly thermolabile hormone. If you allow PTH to be there in the table, if it's there in the collection center, it is not transported on ice, it will go down. So please ensure that the PTH is either taken in ice or transferred immediately, otherwise you will have a falsely low level of PTH. 4-year-old girl with tetany, ionic hypocalcemia, phosphorus levels very high. So hypocalcemia, hyperphosphatemia, PTH high, somebody diagnoses pseudo-hypoparathyroidism. But if we go by our algorithm, the most important thing in somebody who has hypocalcemia and hyperphosphatemia is to do a creatinine level, which was high. So it's extremely important to understand that if you have hypocalcemia with hyperphosphatemia, always look at the possibility of renal failure, because that will be the first thing in that situation. 10-year-old girl with seizures, ionic calcium is very low, phosphorus levels is in the normal range, PTH is low. Now remember, as we discussed about interpretation of cortisol in the setting of hypoglycemia, cortisol should be high. Anybody who has hypocalcemia, the PTH should be high. So his PTH should have been above 70. If his PTH is normal in the presence of hypocalcemia, this is low, and this is an important concept to remember. He had no response to IV calcium, so in that situation, of course, the first thing to look at is magnesium, which was deficient. So hypomagnesemia should be suspected in everybody who has refractory hypocalcemia with low PTH level. We have a 3-month-old girl with seizures and ionic calcium of 3.2, which is very low. Phosphorus levels are also low, and somebody did the PTH, which was low. So if you look in this perspective, this is a diagnostic dilemma. We expect anybody who has got a low PTH to have a high phosphorus. So is it really hypoparathyroidism, which was the diagnosis with which the child was referred to us. Now what we need to remember is that if the phosphorus is low, we are most likely dealing with a vitamin D dependent causes, and in this perspective we have to really question whether the vitamin D is low or not, which was found to be extremely low. And what turned out in this case was that the PTH was not appropriately transported, and therefore this PTH, which was found to be low, was false. So if the phosphorus level is normal or low, the possibility of hypoparathyroidism is extremely low. We have to consider the appropriate transport or a pre-analytical issue in PTH as observed in this case. 1-week-old boy with seizures, hypocalcemia, hyperphosphatemia. This is clearly a situation where we have to do a creatinine, which was normal, and the PTH was low. So this is a classic case of hypoparathyroidism. Very importantly, we have to look at features of DiGeorge syndrome in terms of facies, in terms of fish, and cardiac evaluation in this regard. So hypocalcemia can present with a wide variety of situations which we need to be very careful in terms of assessment. Now we have a 12-day-old girl with irritability, dehydration, and this case happened to be hypercalcemia. So while hypocalcemia is common and often picked up, Hypercalcemia can be mixed, and this can be a lethal condition which may present with severe dehydration and shock in the newborn period. And what was found in this case was that this was a case of neonatal severe hyperparathyroidism because of a calcium sensing receptor inactivation. This condition typically presents early onset with very high levels of calcium. Hypercalcemia should be suspected in all children with severe dehydration with polyuria. Now this is important. Anybody who has dehydration should have oliguria. Dehydration with polyuria suggests the possibility of diabetic ketoacidosis, diabetes insipidus, adrenal insufficiency, tubular necrosis, or hypercalcemia. Hypotonia and encephalopathy should be the other features. So pretty much every sick child should have a sodium, potassium, a glucose, and a calcium level done. And nearly all endocrine causes will be identified just by these 4 basic workups in that perspective. 4-day-old boy with seizures, birth weight was normal, had a birth asphyxia, found to have a very high level of calcium. So now we have to think whether it is a PTH dependent or an independent cause, and what we found that the PTH was undetectable. So PTH is not the cause. Neonatal severe hyperparathyroidism is out in this perspective, and somebody who has got a birth asphyxia with a high calcium, a strong possibility to think of would be a vitamin D excess because of a subcutaneous fat necrosis. So she actually had palpable nodules which have to be excluded and identified very importantly in this perspective. So any newborn with seizures who has hypercalcemia with birth asphyxia, look for skin nodules if they are present. Think of a fat necrosis in that perspective. Now we'll go forward further. We have discussed about glucose and calcium towards electrolyte, and electrolytes are regulated very tightly in the body. One of the most important regulations of the body is actually at the level of the sodium, or we can say the osmolality. While glucose has got a range from, let's say, 80 to 140, which is like so high, calcium between 8.5 to 12. When we talk about osmolality, even 1% change in osmolality will trigger responses. So the osmolality in the body depends upon 2 things, tonicity and volume, which is regulated via the sodium level and the water level. So abnormalities in either sodium or water will be associated with abnormalities with regards to the overall levels of the sodium. And what is important to understand, it is that the primary abnormalities in the setting of sodium disorders, be it hyponatremia or hypernatremia, is actually free water and not sodium. So hyponatremia, the most common cause may be SIADH because we've got more free water, while hypernatremia, again free water loss becomes important. So water is very important to regulate, and for this we have got the thirst mechanism and the urine output. And if there is deficiency of water, we get more water coming in from the thirst, and we will retain the water excretion from the kidneys. And this is controlled via the sensing of the osmolality by the organ vasculosum lamina terminalis and the subfunicular organ in the brain, which triggers the secretion of a very important compound, which is vasopressin. This vasopressin will cause concentration of the urine, retain free water. Conditions associated with excess AVP will cause hyponatremia, while deficiency of AVP or its action will cause hypernatremia. Every child with hyponatremia will have a component of high AVP. Unless the AVP is high, there will be no sustained hyponatremia, and this is extremely important to understand. And this AVP elevation may be appropriate as in the setting of dehydration, as in the setting of a cardiac failure with effective volume loss, or inappropriate in the setting of SIADH. Now, the other major regulator of the body is the sodium regulation and the volume regulation, which is done via the renin, angiotensin, aldosterone system, which basically controls mainly the sodium level. So if the RAS axis goes up, the sodium excretion goes down and the potassium loss becomes more. So renin-angiotensin system will cause hypernatremia with hypokalemia and conditions associated with abnormalities in the renin, angiotensin, aldosterone system, and this includes a congenital adrenal hyperplasia, adrenal insufficiency, aldosterone deficiency, aldosterone resistance will all result in hyponatremia and hyperkalemia, which is the classic manifestation of salt wasting in that perspective. Now, if the volume goes more, sodium goes more, we have the atrial natriuretic peptide which will push the sodium out to ensure. So there are two mechanisms, AVP and RAS, which are building up the volume and sodium, while ANP is pushing out the sodium. Now this potassium can also go into the cell using the sodium potassium ATPase channel and agents which stimulate it, including insulin and beta agonist, will cause hypokalemia in that perspective. Now based upon this, we can understand in most situations the sodium and potassium will go in an opposite fashion. So if your sodium goes up, the potassium goes down. This is typical RAS excess. If the sodium goes down, the potassium goes up. This is RAS deficiency. Now, if both sodium and potassium are high, this is extremely rare situation of Gordon syndrome, while if both are low, this could mean tubulopathy or a GI loss in that perspective. The effects of sodium disorders depend largely upon the fluid flux. We need to remember that sodium is the major regulator of tonicity in the blood. So conditions associated with hyponatremia will result in a passage of fluid into the cells, which will cause swell to swell, and this swelling in the acute stage will result in severe symptoms like coma, seizures, and distress, and this is a dying child with hyponatremia. The only indication for a hypertonic saline is acute severe hyponatremia. Now as time passes by, there will be some balance which will happen and the symptoms will become less in the form of nausea, headache, and confusion, and this is particularly common in chronic cases in which symptoms may not be very severe. We don't need to correct it so rapidly because that can cause more harm, as we'll discuss. With time, there is some process in which the osmoles are generated within the cells which basically are able to really maintain this whole flux. So in the chronic state, the osmoles go out and the cells become normal in size and symptoms become less acute. They are mainly in terms of weakness, cognitive defect, instability, frequent falls, and recurrent vomiting will be there. Very importantly, the symptoms of hyponatremia are related to not only the absolute level but also the rate of change. So a patient with a chronic liver disease with a sodium level of 120 may be perfectly fine, while somebody who has got SIADH in which the levels decrease from 130 to 122 may have a severe symptom. So while we are treating hyponatremia, we are not treating the sodium levels, we are treating mainly in terms of the symptoms. Now once correction is done, there will suddenly be a decrease in the fluid resulting in cells to shrink. So the acute effect of hyponatremia is in the form of cerebral edema, while on chronic status it causes cell shrinkage. The opposite happens with hypernatremia, wherein once the sodium levels go up, there would be a shrinkage of the cell resulting in altered sensorium, high-grade fever, dovey skin, seizures, and hemorrhage. While with time the osmoles will go into the cells trying to bring the cells back to normal, and if we suddenly correct it, there would be a lot of problem. The chronic symptoms of hyponatremia are in the form of failure to thrive, which is a classical presentation which is observed in the setting of hypernatremia because of nephrogenic diabetes insipidus in a child around 6 months to 12 months of age presenting with recurrent episodes of dehydration, fever, irritability, and lethargy. Now, if we correct the sodiums rapidly, there would be a risk of cerebral edema. So hyponatremia causes cerebral edema in terms of initial presentation and cell shrinkage causing problems in the treatment phase, while hypernatremia will cause cell shrinkage in the initial phase and cerebral edema if we correct it too rapidly. Hyponatremia is one of the most common electrolyte abnormalities observed in pediatric practice, and this can represent abnormality associated with increased glucose or decreased sodium. Most conditions will invariably have an increased water as a major form, and these are associated with a normal or an increased volume. Now, since volume assessment becomes extremely difficult in this setting, a good surrogate marker for volume is uric acid. Uric acid secretion is entirely dependent upon the plasma volume. Higher the plasma volume, higher uric acid excretion and lower uric acid. So hypervolemic states are associated with low uric acid and low PCV because of a hemodilution. They typically will be associated with a U or hypervolemic state, while conditions associated with a loss of sodium typically present with dehydration, high uric acid, and hemoconcentration. The most common cause, of course, will be giving too much fluid in the perspective of overload of fluid, which is iatrogenic, or conditions associated with third space loss like cardiac failure, nephrotic syndrome, and chronic liver disease. What's very important to understand is that every condition associated with effective hypovolemia will stimulate the secretion of AVP, worsening hyponatremia. So chronic sustained hyponatremia basically means that there is excess AVP, which may be appropriate in this setting, in the setting of a thyroid or a cortisol deficiency, or inappropriate in the setting of syndrome of inappropriate ADH secretion. And this is a very common cause of ICU associated hyponatremia that we see. As discussed in the index case 1, it is always important to exclude a multiple pituitary hormone deficiency in the setting before we make a diagnosis of SIADH. Now, a common confusion which is there amongst intensivists and pediatricians' mind is that if we talk about cortisol deficiency, we should have hyponatremia and hypercalemia. This is not true, because if we talk about central ACTH deficiency, we only will have hyponatremia, which is basically because of the free water effect of cortisol. There is no hypercalemia because ACTH does not or very minimally regulates aldosterone secretion. So ACTH deficiency will pretty much have a low cortisol with a normal aldosterone levels, and if aldosterone is normal, hypercalemia will not be there. So isolated euvolemic hyponatremia is a characteristic clinical presentation of multiple pituitary hormone deficiency associated with ACTH deficiency, as discussed in case 1, case 2, which we discussed, that newborn with the micropenis, hypoglycemia, and hyponatremia. Now, abnormality in the renin, angiotensin, aldosterone system defects, and this includes congenital adrenal hyperplasia, this includes adrenal insufficiency, aldosterone deficiency, aldosterone resistance, will present with hyponatremia and hypercalemia, which is basically a salt wasting crisis. Abnormalities in the renal tubules like Bartter syndrome, Gentleman syndrome, the use of diuretics will be associated with hyponatremia and hypokalemia. Cerebral salt wasting will be associated with polyuria, increased urinary sodium, along with a low level of serum sodium. Now, if we look at the major causes of hyponatremia, fluid overload will typically be quite visible clinically. SIADH is a diagnosis of exclusion. Diuretic history is often there but sometimes may be missed. RAS defect typically will be associated with dehydration, high uric acid, and hemoconcentration. Renal failure will be associated with hemodilution, and diarrhea, of course, will have a low urinary sodium because it's mainly an extra renal loss of sodium. Now, in this perspective, if we look at investigations, uric acid and volume are very, very important. So if uric acid is low, it indicates volume is high, which basically means fluid overload or SIADH. Urinary sodium should be always less than 25 in anybody who has hyponatremia. A urinary sodium more than 25 indicates a diuretic use, a RAS defect, or SIADH. Potassium, if it's high in the setting of hyponatremia, indicates a RAS abnormality or a renal failure, while hypokalemia and hyponatremia, as discussed, indicates an excessive loss of both sodium and potassium from either the tubules in the setting of tubulopathy like Bartter syndrome or Gentleman syndrome, or the use of diuretics, or from the gastrointestinal tract in the setting of diarrhea. Hemoglobin, if it's high, it indicates hemoconcentration, while low or normal will indicate a hemodilution in that perspective. A very common life-threatening condition which each pediatrician should be aware of is a salt wasting crisis, which if treated properly will be saved, otherwise there could be lethal consequences. The condition typically presents with severe dehydration, shock, hyponatremia, hypercalemia, metabolic acidosis, and hypochloremia. So if you have a sick child who is dehydrated with hyponatremia, hypercalemia, think of a salt wasting crisis. It can also be result from a renal failure picture. Typically there, this hyponatremia is dilutional. So you will have anemia along with a more volume overload state. Very importantly, Transient pseudohypoaldosteronism can be observed in the setting of obstructive uropathy and urinary tract infection that can present with salt wasting in the newborn period, a condition which should also be present with pyelonephritis. And these two conditions have to be confirmed before we label somebody as pseudohypoaldosteronism. So the approach to hyponatremia begins with excluding the possible pseudohyponatremia with hyperglycemia, lipid disorders, or protein abnormalities. Once they are normal, most important thing is to look at fluid status. So look at the volume, look at the JVP, the liver, the edema, the heart rate, hydration status. If it's hypervolemic, it's fluid overload, cardiac failure, renal failure, nephrotic syndrome. If the patient is euvolemic, exclude hypothyroidism and cortisol deficiency. If all that is normal, this is most likely syndrome of inappropriate ADH secretion. If the individual is, however, hypovolemic, look at urinary sodium. If the urinary sodium is less than 25, so there is hyponatremia and there is an appropriate renal conservation of sodium. This is an extra renal loss, like a gastrointestinal loss. If the urinary sodium is more than 25, look at potassium. If potassium is low, it would indicate that there is a hyponatremia, hypokalemia, tubulopathy, or diuretic use. If there is hyponatremia, hyperkalemia in a hypovolemic state with a high potassium, you're dealing with a renin-angiotensin-aldosterone defect. Look at renin-aldosterone level, look at cortisol, look at aldosterone. So approach to hyponatremia basically involves the assessment of fluid status, thyroid and cortisol, and potassium, and that really gives a clue in most cases. So we have a 12-year-old boy with diabetic ketoacidosis. Blood sugar was 700, sodium was 126. So somebody thought this is hyponatremia. But we need to remember that blood sugar is an important cause of pseudo-hyponatremia. Every 100 milligram per dl rise of blood sugar causes a decrease of sodium by 1.6. So we have to add 9.6 to the sodium, which becomes 135.6, which really excludes the possibility of a true hyponatremia. This is a pseudo-hyponatremia in this situation. 1 week old boy with seizures, sodium is 128, potassium is 3.6, so there is hyponatremia and borderline hypokalemia. There is no dehydration, so look at fluid status, and he is not dehydrated, blood sugar is low. So again, the same case we discussed earlier in perspective of hypoglycemia. Now if we look at hyponatremia with hypoglycemia, micropenis, this is a clear-cut case of multiple predatory hormone deficiency resulting in a hypopid state. 14-year-old boy with drowsiness and hyponatremia, the initial case that we discussed. Euvolemic, a urinary sodium level of 100 and a urinary osmolality high, diagnosed as SIADH. But if we really look at our algorithms, in a child who has hyponatremia, normal glucose, and who is euvolemic, you have to look at thyroid and cortisol. Importantly, if cortisol is less than 550, then you have to think of a possibility of a ACTH deficiency. So consider ACTH deficiency despite the potassium being normal, and it should be excluded in everybody who comes to us with SIADH like picture, and this happened to be a MPHD. Now we have a 3-week-old child with failure to thrive. Sodium level is 110. Birth weight was 2500, has hardly gained anything, is dehydrated, is hemoconcentrated. So this is more like a salt wasting. We have to look at fluid, is dehydrated, urinary sodium is high, potassium is 8.4. So this is a classical case of hyponatremia, hyperkalemia, dehydration, hemoconcentration. So this is clearly a salt wasting crisis, and the most common cause of salt wasting crisis in this setting is a 21 hydroxylase deficiency, and this child actually had a atypical genitalia. 17 OHP was sky high and 21 hydroxylase deficiency was diagnosed. Immediate treatment with hydrocortisone will result in significant improvement, but you have to correct his sodium, you have to correct his potassium using calcium gluconate. Otherwise, by the time the hydrocort starts acting, it will be very, very difficult to manage, and this could be life-threatening. So the management of this salt wasting crisis would include a potassium-free fluid, calcium gluconate, insulin dextrose drip, maybe a 3% saline to begin with, followed by a double maintenance IV fluid with 10% dextrose. Also give 50 mg per meter square stat of hydrocortisone followed by 100 mg per meter square per day Very importantly, there is a binding problem with CBG. Once the cortisol level goes above 750, whatever cortisol you give goes in the urine because the cortisol binding globulin is not able to really adhere to it. So the ideal way of giving a high dose glucocorticoid is with infusion. So in this setting, you can give 50 milligram per meter square stat, which will probably be somewhere around 10 milligrams, followed by what you need to do is 20 milligrams to be given evenly as an infusion of hydrocort. Once the child becomes stable, you start tapering the hydrocort dose, and by around 24 to 48 hours, once your hydrocort dose becomes 50 milligram per meter square per day, you add fludrocortisone. In that situation, an initial fludrocortisone requirement may be very high, maybe up to 0.2 to 0.3 milligrams. Start with 0.1 BD, and once your sodium potassium is stable, discharge on around 20 milligram per meter square per day of hydrocortisone and 0.1 to 0.2 milligrams of fludrocortisone. Subsequently, once things are stable, we can switch over to physiological replacement dose of hydrocort of around 8 to 10 milligram per meter square per day in fludrocortisone. Very importantly, do not use prednisolone or dexamethasone in a growing child with CAH because that will cause huge growth compromise. Hydrocortisone is readily available and it is the treatment of choice in that situation. An interesting case, 6-month-old girl referred as cystic fibrosis to a pulmonologist, failure to thrive, chest infection, sweat chloride was found to be high, but did not have any steatorrhea, so they got a bit worried. They worked up and found hyponatremia and hypercalemia, and that's when the endocrine referral came into the picture. And this is a classic presentation of the severe epithelial sodium chloride channel defect, the pseudo-hypoaldosteronism type 1. Autosomal recessive variant, wherein the problem is basically at the channel which shifts the sodium and potassium chloride, and this can present with recurrent chest infections, high sweat chloride, and is a differential of cystic fibrosis. But of course, cystic fibrosis will not cause hypercalemia. So hyponatremia and hypercalemia is a clear-cut marker of a renin-angiotensin-aldosterone system defect, as in this case pseudo-hypoaldosteronism, which was identified. Another very important case to discuss from a pediatric perspective, 1-month-old boy with reduced feeding, birth weight was 3100, has around 100 gram gain in this 1 month period, which is pretty low. Hyponatremia, hypercalemia. So of course the first thing you will think of is 21 hydroxylase deficiency in somebody who is a phenotypic male. 17 OHP level was done, which was normal, and cortisol was high. So what we are seeing here is that there is a male with salt wasting who has a normal genitalia, whose 17 OHP levels are normal and cortisol are high. So a combined adrenocortical insufficiency is out. We are dealing either with the aldosterone deficiency or resistance. So now we did a renin and aldosterone which levels were high. So this goes in favor of pseudo-hypoaldosteronism. But what we need to remember is that there is a transient form of pseudo-hypoaldosteronism which can occur with a renal tract obstruction and UTI. And this is something which we have to really exclude. And in this case, what we observed that the urine showed a pyuria and there was a clear-cut obstruction. So obstructive form of pseudo-hypoaldosteronism should be excluded in everybody who presents in the newborn period with sudden onset hyponatremia and hypercalemia after we have demonstrated a normal 17-hydroxyprogesterone and a cortisol level. Management of hyponatremia is guided entirely by symptoms. If it's acute severe, we give around 3 to 5 ml per kg of 3% saline over 20 minutes. Very importantly, we only want to build up the sodium levels till the symptoms go down, and that is typically around 5 to 6 millimoles per liter. In severe cases, we may think of a 3% saline infusion. 1 ml per kg per hour of 3% saline causes a rise of 1 millimole per hour of serum sodium. The 3% saline should only be given till a patient is symptomatic, and we should not increase the sodium levels beyond 12 because of the risk of those problems. Acute moderate forms, we should avoid the fluid bolus. The rate of rise should be less than 6 to 9 millimoles per liter per day. In chronic cases, there is definitely no indication of acute therapy, particularly for liver disease, because that can cause a lethal outcome. And rise should be less than 6 millimoles per liter per day. There are equations which are there which take into consideration the fluid deficit, how much is the hyponatremic sodium deficit, the isotonic sodium deficits, maintenance, correction in fluid, and then there are complicated formulas. We have made a very simplified equation within our applications. All you have to put is what's the weight of the child, how much is the sodium level, what's the desired rate, and that also is given. So if you want to raise by 6, which fluid you want to choose, you will get how much fluid rate is required for that particular child. So this will make it much easier and much uniform. 14-year-old girl with failure to thrive, birth weight was 2600 grams, has actually lost 300 grams of weight. She is breastfed, and this is a lethal condition which is common particularly in primigravida mothers who are not aware that the child is content or not with regards to feed. Sodium very high, and this breast milk related hypernatremia is a lethal condition. This condition is not really because of a high sodium content in the breast milk, but it's rather a dehydration state. So they are basically primigravida mothers who don't really understand how much feeding is enough for the child. The child is drowsy because of hypernatremia, looks sleepy, lethargic, passing 1 to 2 urines per day maximum, and the mother is also happy that the child is not crying. He's a happy child. But any newborn who is not gaining weight by regaining the birth weight by 2 weeks or maximum 18 to 21 days is at risk of this condition, and the sodium should be monitored in that perspective. In this case, what we found that urinary osmolality was very high, urinary sodium was very high, and this condition basically is breast milk related hypernatremia. The management is essentially a same way that we discussed about the dehydration correction, and then stimulation of breastfeeding, and if it's not possible in rare cases, to think of formula feeding to ensure that the dehydration goes off in that perspective. So hypernatremia is common in the neonatal practice, can present with seizures and altered sensorium. Very importantly, their dehydration may be missed because the skin is duffy. There could be fever as an important manifestation. Hypernatremia can be because of free water loss, which is associated with dehydration, or it can be because of a sodium gain causing fluid overload. As we have discussed, free water problems are major causes of sodium abnormalities that are encountered in clinical practice. So hyponatremia is more common because of fluid overload. Hypernatremia is more common because of fluid deficit. A fluid deficit can happen because of reduced intake, gastrointestinal or a urinary loss, diarrhea or sweating. Diabetes insipidus, of course, is the most important chronic cause of hypernatremia. From a clinical perspective, the most important cause of hypernatremia would be an inappropriately prepared ORS solution, which is very concentrated, causing that sodium level to go up. High RAS generally does not cause hypernatremia because in that case the atrial natriuretic peptide will come into the picture and it will cause sodium loss. From that situation, sodium load is unlikely. So we're mainly talking about diarrhea, ORS problems or DI as the major cause. 3-month-old girl with altered sensorium has hypernatremia, hypokalemia, urinary osmolality is low. So there is a concentrated blood and a dilute urine. Somebody thought that let's think of DI, diabetes insipidus, do a water deprivation test, and the child develops seizures. Now this is a fatal mistake. The reason we do a water deprivation test is to build up the sodium level beyond 145. If somebody is already hypernatremic, why would you do a water deprivation in that setting? So this child is actually DI. She has hypernatremia and she has low AVP. So this is DI. Do a AVP response. Never do a water deprivation test in somebody who already has hypernatremia. 13-year-old boy, a common presentation in the intensive care setting, had encephalitis, was quite sick, and on ventilator suddenly starts to pour a lot of urine. Sodium is very high, urinary osmolality is low. This is what was considered as a brain death DI. This basically happens because of a diffuse neuronal damage, and this situation basically means that the large part of the hypothalamus is gone. The AVP neurons are very widely distributed in the hypothalamus, so if there is an extensive injury ranging for a few centimeters in this critical region, it basically means that this is the end of the story. So if somebody who is quite sick with diffuse brain injury starts pouring urine, think that brain death is very close in that situation, very difficult condition. We may give a low dose vasopressin infusion 1.5 to 5 milliunits per kg per hour, but that is just a symptomatic therapy, won't improve the prognosis of the child. Now, management of hypernatremia basically depends upon the symptoms, but usually we want to correct it slowly over 48 hours. Do not correct it more than 9 to 12 in acute and 6 to 9 in chronic hypernatremia. The calculation includes the free water deficit, which is 4 ml per kg with regards to the sodium level. We can correct the maintenance and ongoing loss. The protocol, basically, we have to consider the normal saline bolus if required, and then even correction. If a child is able to take it orally, it's always better. Otherwise, traditionally, sodium content of 70 to 100 millimoles per liter with 120% maintenance is usually what is required, and dialysis is indicated, of course, in severe cases. Now, we have this, again, similar way, complex way in which you can assess depending on the fluid deficit, the free water deficit, the isotonic deficit, and looking into all the perspective. And we also have got the app option, which basically just puts into the picture. And once you put all the figures, the level of sodium, the desired rate of correction, and which fluid, whether 0.9 or 0.45, you will get the exact fluid amount which is required in that perspective. Now, hypokalemia is more commonly associated with renal abnormalities, but certain amount of endocrine causes, particularly the RAS excess syndromes, are associated with hypertension and hypokalemic alkalosis. The symptoms of hypokalemia typically start happening once they are less than 3, starting with polyuria. Myopathy typically starts between 2.5 to 3 with weakness, ileus, and spasm. Paralysis and rhabdomyolysis occurs when it sits less than 2. The cardiac change is typically below 2.5, and then you can have a severe cardiac arrhythmia and ventricular tachycardia which are there. Hypokalemia can theoretically be because of an intracellular shift of potassium because of insulin and alkalosis, and this may happen with treatment of DKA. This may happen with the refeeding syndrome where the insulin level goes up, beta agonist in chloroquine and channelopathies. There could be intestinal loss because of diarrhea, vomiting, or NG aspiration, renal loss because of metabolic alkalosis per se, the use of diuretics, Bartter-Gilman syndrome, and of course RAS defects, the RAS excess syndrome in which there will be hyperrenism. There is increased level of aldosterone, aldosterone-like compounds like DOC, increased epithelial sodium chloride channel, increase, which is the Little syndrome basically in that situation, Gordon syndrome, in which all there will be a condition of hypokalemia which will happen in that setting. There could also be osmotic diuresis rarely. So from an endocrine perspective, we are mainly talking about hypertension and hypokalemic alkalosis. The evaluation, of course, the most important investigation in a child with hypokalemia is the acidosis assessment. Every hypokalemic child should have a metabolic alkalosis. If there is metabolic acidosis with hypokalemia, it indicates renal tubular acidosis or gastrointestinal loss or acidozolamide use. In this situation, we should look at urinary anion gap. If it's positive, it is renal tubular acidosis. If it's negative, it is diarrhea. Alkalosis with hypokalemia can be because of a number of causes. So we have to look at blood pressure, we have to look at renin activity, aldosterone, and magnesium level. Urinary potassium, if it's more than 100, indicates renal loss, and we can look at urinary potassium to creatinine ratio. Transtubular potassium gradient is of limited role in evaluation of hypokalemia at the moment. Very importantly, correlate sodium levels. So we expect the sodium to be high or normal in a RAS excess state. If the sodium is also low, it is GI loss or diuretic use. Now, the important causes of hypokalemia includes diuretic use associated with hypovolemia, malnutrition associated with hypomagnesemia, Bartter syndrome associated with hyponatremia, Gentleman with hypomagnesemia, RAS excess with hypertension, RTA, and diarrhea with acidosis. So we have to look at volume. If the volume is high, it means RAS excess. If the urinary chloride is low, it indicates RTA and diarrhea. Acidosis, again in hypokalemia, indicates renal tubular acidosis and diarrhea, while hypomagnesemia may be a feature of malnutrition, diuretic use, Gentleman syndrome, and if there is hypertension, there could be a RAS excess. So urinary chloride, volume, pH, magnesium, and blood pressure are the most important workup to look at in this perspective. The approach to hypokalemia starts off with evaluation for diuretic use, malnutrition, and gastrointestinal loss. If they are not there, look at blood gas. If there is metabolic acidosis, and then you look at urinary anion gap. So urinary anion gap being positive indicates renal tubular acidosis, negative means gastrointestinal loss. Metabolic alkalosis, look at blood pressure. If it's normal, look at urinary calcium to differentiate Barter's and gentlemen. If the blood pressure is high, look at aldosterone. If it's high, it is of course a hyperaldosteronism. If it's low, exclude the CAH variants which may present with hypertension and genital ambiguity. If they are high, say the CAH variant. If it's normal, look at Lidl and apparent mineralocorticoid excess, which are differentiated based upon response to spironolactone. So the approach to hypokalemia begins with blood gas evaluation, followed by urinary anion gap for acidosis, blood pressure evaluation, renin and aldosterone evaluation for somebody who has hypertension. 8-year-old boy with high blood pressure, and this is a very, very interesting case, basically short, presented with precocious puberty, had metabolic alkalosis and hypokalemia. The blood gas showed hypokalemia and had hypertension. So this is a child clearly with RAS excess, and when we evaluated, he had bilateral cryptorchidism. So this is a very, very interesting situation of a girl or a XX child who presents with extreme virilization because of a 11-hydroxylase deficiency, resulting in a male appearance with precocious puberty, and this is an important consideration to think of. 1-year-old boy with failure to thrive, polyuria and blood pressure on the higher side, hypokalemia with metabolic alkalosis. In this situation, renin and aldosterone are both low. So this is a situation where there is a apparent aldosterone excess with aldosterone deficiency. So in this situation, urinary steroid profile was done and response to aldactone was suggestive of an apparent mineralocorticoid excess state, which will respond to spironolactone. So a careful evaluation for endocrine causes is essential in the setting of hypokalemic alkalosis with hypertension, as in this case. A 2-year-old girl with failure to thrive with hypertension, hypokalemia, and what we see is that renin was low, aldosterone was undetectable. In this case, further workup showed that there was no response to aldactone, but there was a response to amiloride, indicating a possibility of Little syndrome. So we need to be very, very careful in terms of evaluation of these causes, and this involves a careful assessment of a number of conditions in this perspective. Having discussed about glucose, calcium and electrolytes, we'll go through quickly about 3 other aspects of sexual development which may present as a emergency, both endocrine as well as a social emergency, thyroid and adrenals, and how their variations can have an impact in terms of clinical presentation. So this is a day 1-old child who presents to us with a single opening, no gonads, labial fusion, Prader 4. What should we do in that perspective? So the first question is whether a child has a DSD. So a disorder of sexual development can be defined in the newborn period with clear-cut genital ambiguity. Cryptorchidism in an apparently normal male is a strong suggestion to a possibility of a 21-hydroxylase deficiency, as is a penoxidil hypospadia for DSD. Very importantly, later in life, primary amenorrhea in girls and inguinal swelling may be markers of DSD. Now, while we talk about DSD, we should not unnecessarily work up girls who present with predominant clitoris, particularly in the newborn period, because in that case, there could be a labial edema, which is there. This is labial adhesion because there you can see that there seems to be an adhesion, but there is no clitoromegaly, and penile hypospadias do not require evaluation. The most important things to look at in a child with suspected DSD are whether the gonads and the Mullerian structures are there or not. So if there is only Mullerian structures, no gonad, this is basically a XX DSD. If we have got only testis but no Mullerian structure, this is XY DSD. If we have got both testis and Mullerian structure, it means that either the AMH is not there, it's not working, or it's a ovotesticular DSD. While if there is no uterus, there is no gonads, it means that at some point of time testis was there, which produced AMH, which caused regression of Mullerian structures, and this was anorchia. So the initial evaluation is a combination of gonads and uterus, and you will get to the diagnosis properly. So the approach basically involves assessment of the palpable gonads, whether they are there or not. If the palpable gonads are associated with Mullerian structures, it means there is an AMH issue. If there is no palpable gonads and Mullerian structures are present, think of CH most likely. Otherwise, the workup for XY-DSD becomes complicated, and this involves a careful correlation of the salt status, hypertension, as we've discussed. Day 3 child with DSD, Prader 4 with no gonads. So what we need to do in this perspective is to see whether they are palpable gonads or not, which were not there in this situation. Now Mullerian structures are there. Yes, it asks for 17 OHP, which was very high. So based upon our app, it is very, very easy. So this algorithm may look quite complicated, but we have tried to put forward this whole algorithm with all its combinations which are there. So each and every diagnosis that we discussed there, starting from Smith-Lemeli-Optic syndrome to 11-hydroxylase to 17-hydroxylase to AMH resistance, they will all come up as the option depending upon the clinical situation. So all you have to do, and this becomes a very easy thing because we're not talking about karyotype to begin with, we're talking about basic workup which is easily available to do in that situation, and you'll get it through the app very easily. 10-year-old girl with clitoral enlargement, phallic size 2.2, bilateral gonads present, uterus is absent. So there are gonads, uterus is absent, so it's of course XY-DSD, testosterone is high. So what do? We look at atypical genitalia. Yes, gonads are present. Yes, Mullerian structures are not present. Testosterone, is it high? And we are given actually the range also, so it's not below the range. So you need to do a testosterone to DHT ratio, and then you will be getting the diagnosis of androgen insensitivity syndrome. And very importantly, it talks about consideration for genetic tests. So this approach pathways of the MedEClasses applications are really, really helpful to go through very complicated aspects of pediatric endocrinology in a very simplistic manner, as we saw in this case. Now, thyroid disorders can also present as emergency, and this is a 5-year-old girl with respiratory distress. You see a huge cardiomegaly, pericardial effusion, was admitted for TAP, but then was found to have hypothyroidism. So everybody who presents to us with cardiac effusion, please get a thyroid profile done. 13-year-old girl with altered sensorium, hyponatremia, euvolemic, urinary sodium is high, considered as IIDH, but this is of course hypothyroidism as discussed. So hypothyroidism should be considered in a wide variety of pediatric presentations, from growth failure, early puberty, late puberty, motor delay, hyperandrogenism, fatigability. But from an ICU perspective, intensive care perspective, think of in the setting of cardiomyopathy and hyponatremia. Very important thing to remember in the context of thyroid function evaluation in a child who presents to us in an ICU setting is that the non-thyroidal illness really has a huge impact on the thyroid functions. So with illness, the body basically tries to shut off thyroid because thyroid is going to waste a lot of energy. So what it does, it inactivates the thyroid via increasing the monodeiodinase 3. So the inactive form of RT3 increases, the active form comes down. But to ensure that the brain has got enough amount of thyroid, it increases the local monodeiodinase 2, causing greater level of T3 in the brain, causing a suppression and low levels of TSH. So typical problems in the setting of illness are associated with low TSH and low T4, which can often be confused as what is known as a central hypothyroidism. But remember, this constellation of low TSH, low T4, low FT3 and low FT3 indicates most likely a non-thyroidal illness. On the other hand, if the TSH is high, if somebody has admitted in the ICU and his TSH is 40, of course this must have been more than 100 suppressed because of the non-thyroidal illness, it does not mean that this child does not have hypothyroidism. So if the TSH level is more than 10, this may be an appropriate thing to treat. Remember, dopamine, which is often used in the pediatric and the neonatal ICU setting, suppresses TSH. So that may falsely result in lower TSH, and this may result in misdiagnosis of congenital hypothyroidism if we do a screening at that time. Therefore, all preterm babies, all babies who actually have been on intensive care should have a repeat congenital screening for thyroid at around day 21 of life. Now, once the body recovers, the thyroid function is again required. The MDI3 goes down, MDI1 goes up. So T3 will go up, MDI2 will go up. So brain will say, okay, we need more TSH. So recovery may have a high TSH, low T4, normal T3. So in illness, it may be suspicious of a central hypothyroidism. With recovery, you will have a picture which is suggestive of a compensated hypothyroidism. So thyroid functions should be avoided during illnesses and should be done follow-up after 3 weeks. And if the TSH is more than 10, better treat. 11-year-old girl with pneumonia, low FT3, low FT4, low TSH. So this is really a need for treatment? No, this is a typical non-thyroidal illness. Once you repeat, you will see that picture of evolving hypothyroidism, which will again improve over time. Finally, a few words with regards to the adrenal aspects. A 12-year-old girl in the ICU setting with fever, sudden deterioration, hyponatremia, hypercalemia, petechial rash, and flank mass. So this is a very, very important consideration of Waterhouse-Friderichsen syndrome or adrenal hemorrhage. Now, adrenal hemorrhage typically can happen in the newborn period, where it presents with a flank mass along with microscopic hematuria. Flank mass with gross hematuria means renal vein thrombosis. Flank mass with microscopic hematuria may indicate adrenal hemorrhage. Similar picture can happen in the setting of meningococemia, and this is the typical Waterhouse-Friderichsen syndrome. Management again is a 100 mg per meter square hydrocort over a 24-hour period, preceded by a 50 mg per meter square bolus in that setting. Cortisol deficiency is important consideration in the ICU setting, should be suspected in everybody who has hyponatremia. Remember, hypercalemia is only a feature if this is a primary problem of the adrenals, wherein the aldosterone is also affected, while if there is a central problem, only the sodium may be affected. Headache, hypoglycemia, fatigability, hypotension, hypercalcemia, they may all be features of cortisol deficiency. 12-year-old boy in septic shock in the ICU, multiple fluid boluses, vasopressors, no increase in blood pressure, cortisol was found to be low. This is what is known as critical illness adrenal insufficiency, and this is something like that you have lost all the stores of cortisol, and therefore this has resulted in this adrenal insufficiency. There would be an improvement with the use of hydrocortisone in this setting. So very importantly, we need to be aware of the critical illness adrenal insufficiency in somebody who has a catecholamine refractory shock. Now, what we have seen through all this whole pathway is that how a MedEClasses app can help you in terms of approach, in terms of management. If you want, we have got an intensive care course in endocrinology as well as a course in pediatric endocrinology which can be accessed at this point.